My name is Linda Protopapis, and I'm the Executive Vice President of Sales for HealthRecon. We would like to welcome everyone to our webinar, All Things Z-code Related. To walk us through this, it is my honor to introduce you to our Director of Laboratory Services Support at HealthRecon, Mr. William Baus. William has over 15 years of experience in healthcare revenue cycle management. His last decade has been entirely focused on laboratory revenue cycle management, building onshore, offshore, and hybrid teams to satisfy the needs of his clients. William has worked inside laboratories as the internal revenue cycle director with preview over every step of the revenue cycle process, as well as managing RCM vendors. William is tirelessly focused on compliantly maximizing the revenue for laboratories, whether that is through adoption of technology, application of deep state knowledge of payer and national coding policies, or providing access to relationships that can change the bottom line for labs. A few reminders to all of our attendees: if you would like to ask a question, you may do so by sharing questions via the chat box or by raising your hand, upon which I will be calling on you to enable your audio. Following the conclusion of the webinar, please take a few minutes of your time to fill out a short survey. Let us know what you liked about this webinar, how we can improve, and what other topics you would be interested for future webinars. As a reminder, the recording of this webinar will be sent out via email to you by next week. With that email, it'll also ask if you would like additional information or a demo from HRC. If you can click on that, we'd be more than glad to assist you. And with that, William, show us all yours.
Thank you, Linda.
You are welcome.
And welcome everybody who's joined. All things Z-code related, HealthRecon delivery. And a couple of things I wanted to say up front. Any comments, recommendations that we're talking about are not something you should just use without consulting your billing and revenue cycle leadership. And perhaps if there's anything legally related, you would talk to your own lawyers about it. We're not going to take responsibility for anything you construe from this discussion and that has a bad impact for you on your income. Unless you've been talking to us and we're managing it, then you've got something to say to us. But if you do it on your own, make sure you refer to your own revenue cycle leadership for appropriate implementation of what we're about to discuss. Okay, so here's the agenda that we're going to go through today. So there's going to be some basics about Z-codes and MolDX, and then there's going to be some very specific things about what's happening with our syndromic panels and PGX, and what's going on with Medicare Advantage and UHC, and what about other commercial payers, and how it all fits together. But until you understand what a Z-code is and how it actually works, you're going to have some confusing questions about, well, do I really need a technical assessment approved or not? And the answer to that is yeah, because that's the only point of having a Z-code to begin with. But if you don't understand what a Z-code is, then you ask those kind of questions, and then you'll get yourself into some scenarios that might not be good for you. Okay, so what is MolDX? Okay, so MolDX is the Molecular Diagnostics Program, and it identifies tests using something called a DEX Z-code. I might refer to that in this conversation or in others as just calling it a Z-code. When I use the term Z-code, I mean to encompass the entire totality of a Z-code, which is a Z-code and a successfully completed technical assessment that says covered on it at the bottom of the Z-code card on your DEX exchange. Then you have an active covered Z-code. Okay, so determine coverage. So no coverage, no payment, or that's how it's supposed to work. And certainly, if you've been involved in the past 2 years of what's been going on with PGX and syndromic panels and how that all has impacted and how the adoption of the 87,000 series codes has impacted everybody. Well, people were still getting paid from some of the Medicare Max for a period of time. And this caused a lot of confusion. And I think we just all need to understand that Medicare or even a commercial payer may tell you what they're going to do and then not be ready to do it at the beginning of all of that, or expect you to kind of pay attention and know the rules, and then you might find a way around their system where they end up paying you for something when they shouldn't have. So a Z code was used to identify the test and classify the test, and we're going to get into the details of that so that gets more solidified. And it determines reimbursement. So like if there is a CPT code and you are given that CPT code for your test, well, then they're going to follow the clinical laboratory fee schedule, which is released quarterly by Medicare, and you can then see what your dollar amount is that you're going to get for that. If it so happens that your test utilizes a not otherwise classified code, or so like 81479 is the molecular version of that, 87999 is the microbiology version of that for infectious disease, or you use even a NOS code, which is a not otherwise specified code, like an 87798, which would be a not otherwise specified code for an infectious pathogen for a qualitative test, right? You will then be given the price for those codes from Palmetto. From MolDX, excuse me, I should say MolDX. It is intended to reduce documentation review requirements, and you can kind of somewhat confirm that, that you do get a reduced documentation review requirement in that if you've got a Z-code and a technical assessment successfully passed, it's very rare that I'm going to get from Medicare a documentation request. What happens with UHC when they start doing this? That'll be another story. And that's their favorite thing to do, is ask for documentation. So we'll have to see. Another thing that's important about understanding MolDX is it was originally developed by McKesson in 2011. And it was originally designed as to be a round table for payers and laboratories to come together and be able to accurately communicate and identify the uniqueness of a laboratory's test, and therefore classify it for payment better. It does appear to be used as a tool right now to just simply prevent payment, but that's not what it was originally designed for. Well, subsequently, at a later time, Palmetto GBA ends up purchasing the MolDX program from McKesson. And then to also kind of give you a little context about Medicare administrative contractors and their relative ownership. So Blue Cross Blue Shield of South Carolina owns Celeron, which I'm not even sure how you pronounce that, but Celeron actually owns Palmetto and CGS. And so you'll also notice even in Novitas, which is not a MolDX MAC, it's owned by Blue Cross Blue Shield of Florida, as well as First Coast Service Options, the Florida Medicare administrative contractor, are owned by Blue Cross Blue Shield of Florida. So you kind of see that this kind of stuff, there's a hierarchy to ownership. And it'll also explain why, for example, you'll see who actually does use the MolDX program. It's related to these ownership entities. Now, why do you care what a MAC is? So these are what Medicare administrative contractor MACs look like. They are private companies. They're not government entities. They're private companies that have been awarded a geographic jurisdiction. So as you can see, Noridian's got these two different jurisdictions, but they run all of these states. They're the ones who decide if they're paying and how much they're paying for what Medicare allows them to pay for. And so they're given a budget, and they have to, well, their objective is to be under that budget, which they are then incentivized to be under that budget. And then they get to keep some of the money that they're under the budget for. So they get kind of like a kicker on it. But I think it's important to know they're not really the government. They're private companies owned by other private companies, right? So why you care about who is a MolDX MAC in this context is, well, who is required to utilize a Z-code in the technical assessment then, right? So anybody in JEJF Noridian, an interesting little tidbit, if you end up looking for policies for Noridian, they'll actually have two separate policies, one for JE and one for JF, but they're always lockstep verbatim. at least in the context of everything I've ever viewed for laboratory. I'm not sure if they're that way for every service that they do, but it does seem to me that they're exactly lockstep, and I'm not sure why they bother to split them out because I've never noticed any difference. Novitas is JH and JL, which is not a MolDX MAC, but they only ever produce one policy. So go figure why they make the difference. But if you're in Noridian, JEJF, or you're in WPS, J5 or J8, which they only produce one policy as well, or you are in Palmetto for JJ and JM, again, only one policy, or you are in CGS, J15, they only produce one policy because they're only one location anyways. Any of those states, of which I believe that's 27 or 28 states, if you're in any of those states, you are billing anything that starts with an 8.1 and some of the 8.7s, anything that tests DNA or RNA, you're going to need a MolDX Z-code and a successfully completed, passed technical assessment that says covered on the Dex exchange. When it says covered, that's when you're supposed to bill. You're not supposed to bill when you have an active Z-code. The active Z-code just represents that you can go back to that date for submitting claims so long as you're within the timely filing submission limits, and possibly even appeal if you were outside of it because of some extended work you had to do on your technical assessment, assuming that you were actually running the test that way from the day that you had your active covered Z-code. So Palmetto, CGS, Noridian, WPS, that's MolDX. Blue Cross Blue Shield of South Carolina, because they own them, they've been using it. Medical Mutual of Ohio and Fallon Health, also owned by Celeron, so no big surprise there. That's why they're using it. But now we have a new entrant into the market, and this is UHC, which will happen in August. Starting in August for commercial plans. But I'm going to walk you through what's been going on with Medicare Advantage plans, what's been going on with Medicare in general, and what is going to happen to us with commercial payers here in the future. And I'm going to have to kind of go back and forth on this a little bit so I can pull up the additional documents. But so what exactly is a Dex Z-code? It is a 5-character alphanumeric code identifier for a laboratory test. Not a diagnostic code that starts with a Z, which can be confusing because we also call those Z-codes. It is unique to the laboratory and particular to the test. And you're going to see that. I'm going to get into a lot of detail about that, but one thing to kind of start keeping as a takeaway, if you really understand what that simple sentence says, you would understand then that if you send a test out to somebody else to run it and you need a Z-code to bill it, you need to use their Z-code because the Z-code is talking about and describing the test that you run. And it is these type of details that I will really try to highlight so that a lot of other questions that accrue come up because of not just understanding the basic elements of what a Z-code is. So while this may sound a little boring, it will help you to understand this, to be able to answer the 10,000 questions you're going to have that come up later when there's an implementation of something happening. Okay, so if you reference a test, you use Z-code from that lab. It is not a replacement for a CPT code. It is additive to a CPT code. And in general, you can expect that you will be only billing one CPT code. Now, there is a big exception to that, and that is in PGX. And when we get to the PGX section, I will get into that in a lot of detail. Okay, so again, I tried to talk about the codes from a top-down level. The easiest way, if you're not going to try to remember CPT codes and test group options the way somebody really involved in billing will, what will be easy to take away from this is if you're doing DNA or RNA or mRNA or mDNA or whatever it is that you're looking at, the molecular structure of the two halves of what goes on for replication of cells and how that genetic information is stored, then you probably need a Z-code for it. And they go for, an explanation of trying to give you code ranges of what it is and the tier 1 and tier 2 and GSP and MAAA codes. And PLA codes, and a PLA code is a proprietary laboratory analysis code. You'll notice them because they start with U's, and you'll see that half of the 250 codes that United's talking about for their commercial plans are actually PLA codes. And then most recently, we had the 87,000 series codes, which are technically listed in the coding book under microbiology because they're not testing a part of the body, but you are looking at DNA and RNA. That's why you're needing the Z code for it, right? And also, it's a really good way to make sure not to pay you. All right, Medicare Advantage plans, what lab tests require Z code? So we're going to go back a couple of slides. So I've got it up here, and we're going to look at a couple of things together real quick. All right, that's that. And let me get this. Okay, there we go. Pull that over. So the Medicare Advantage plans. Now, this isn't just for United. This is any Medicare Advantage plan. And they started doing this in October of 2022. And what was interesting in October of 2022, or maybe it was 2021, but I think it's 2022. The first thing that they said was, look, it's only going to be for laboratories that are in a MolDX MAC. And then in April, they came back and said, no, it's for everyone now. So any Medicare Advantage plan, not just United Medicare Advantage plans, is well within their rights now after they've gone through 9 waves of CPT codes, and these are all of your CPT codes. If it's doing DNA, it's very likely that they're well within their rights to ask you for a Z code and a technical assessment being successfully completed. And they're going to look at that and they're going to process the claim. And if you don't have it, then they're not going to pay you. Now, if they're not doing it to you yet, they're also well within their rights to come back and ask you for it and take money back if you don't have it. So just because you get paid from these people who are trying to implement a completely new system for adjudicating claims and they're not doing a great job of it, don't think that that means it's any kind of certification of or any validation of that you're doing the right thing, because they will make mistakes and pay you. And Medicare has done that for almost an entire year for a lot of people on their UTIs and their nails and wounds, right? Although I think it's pretty well understood now that people do get denials now looking for their Z code, but it just took them almost a year to actually implement it. And yeah, you are in danger of a clawback. They would be well within their rights to ask you where your Z code was for the stuff they were paying you after month 6 of 2022, right? So now there's definitely a distinction though between what's happening with a Medicare Advantage plan versus a United Healthcare commercial plan. All right, now the difference is what CPT codes they're talking about and when will it be implemented. So again, what you're looking at on screen right now, Linda, everybody can see the screen. I've lost my little green bar. Am I still connected? Did I get dropped off?
Yes, we can see your screen.
Okay, good. Panic attack there. I'm like, how long have I been talking with nobody there? So you've got these 9 waves. And so they kind of release these every month, or, you know, like this one was June, this one was July, this was in August, this was in September, and then after November. And you notice they start, you know, there's a lot of anything with a U code on it. You can tell that's a PLA code, proprietary laboratory analysis code. You would know if you need to use that code or not, because you would have bought some probably FDA approved test with and they would have told you what U code you need to use for billing it. But what's kind of interesting to me in this is there are 87,000 series codes in here, but it's really 87801 and 87999. And I think and there wasn't even an 87798. So like even from a Medicare Advantage perspective with respect to infectious disease testing, you'd really only need a Z code on these bundled codes, right? And 87999 is likely to be the code you're given when you do, well, if you did a UTI, nail, or wound and you somehow were able to get past their clinical utility issue, where you don't have clinical trials that are reviewed in peer-reviewed literature that address the issue about false positives, which is their thing that they're clinging on to desperately to not allow you to get a Z code for that. But if eventually you do get past that, or NILA or Thermo Fisher, whoever's working on getting those clinical trials done, when they finally get that clinical trial done, you're probably going to get an 87999, and then they'll tell you exactly how much they want to pay for that panel. And at that time, I would recommend a small targeted 3 to 5 panel target panel, and then have a bigger panel. But if that bigger panel, then that's when you talk about a specialized population with immunocompromised diagnostic codes, and then you might get that one covered too under those conditions. But so really, what this is going to impact most people on are your basic cancer diagnostic code tests like BRCA, and then any NGS tests that would kind of block you. I mean, like your Parkinson's, Alzheimer's, dementia, or your neurology panel, some people might call that, or your immunology panel, or the diabetes and obesity panels, those NGS panels. A lot of the codes you would be using to reflect that are covered here, but it still isn't the full code set of 87,000 series in much the same way that you would see in the syndromic panel LCDs. So that's kind of interesting, right? Your Medicare Advantage plans, that means a lot of the codes you would be billing for your infectious disease are still kind of going to get paid for, and you don't have to worry about them, right? Now that is in particular relationship to the Medicare Advantage plans. And then, to be absolutely clear, that's for all Medicare Advantage plans, not just United. And they have already released out through Wave 9. So any of those codes, if you're doing them, they're well within their rights to ask you for a Z code or deny you for not having a Z code. And yeah, even if you have a Z code that's active, but it's not covered, they should be denying you. And if they pay you, that's an accident, and they can come back and ask for that money anytime they want, unless you end up having a covered technical assessment, a covered Z code. All right, so then let's look at the next one, and let's talk about United and how does this particularly impact United. So here we have the United PDF. And so they did Wave 1, or they've told us what Wave 1 is going to be on August 1st of 2023. And it is these roughly 240 to 250 codes. And then I'd say about half of them are PLA codes. Any of these that start with these U's, these are all PLA codes. So as you can see, it does include PGX, right? So you've got some of these 226, 225, 227. Those are your, the CYP 450 chromosome set of codes. You've got an 81479. So, that's going to effectively prevent you from trying to bill an 81479, which is your unlisted code. So you're going to need a Z code for that one. If if you're doing any testing that didn't have its own CPT codes, that's going to be particularly troublesome for you. And then, of course, you've got some CGX in here. So you just really kind of need to look through what you're billing to see if you already need a Z code in August. But another way to look at this is, it's coming. Guess what? There's going to be a number of waves. Obviously, there's going to be less waves for these guys because, as you can see, for the Advantage plans, they kind of did a slower rollout. It was kind of a pre-up of how they were doing all this, and they got bigger and bigger as they went in. You can expect that there will be more waves, and eventually it will encompass anything that's talking about doing DNA or RNA testing. And if it follows a similar time frame for rollout, you're looking at about a 9-month rollout. So, through the end of this year and into next year, you're going to see that. And probably at the end of that is where you will see the infectious disease, if it patterns, the release pattern of this is similar to how they did the Medicare Advantage plans. Now, Another thing that is going to be specific about this is this is related to commercial plans. And so the next question then should become, well, they're using this to replace Beacon. And Beacon you only had to do when you were in network. The way that this is being written is as if it's talking about in or out of network, although that was not explicitly specified, but a call was made to the payer, and they did say it was for in or out of network is the requirement. So I would expect it to be that. And I have had folks question, well, do you need a Z-code and a technical assessment successfully passed? Because they don't explicitly state that, but I also think that that's just a lack of understanding of what the purpose of a Z-code is, because a Z-code by itself is entirely useless and irrelevant, and you'll see that here in a moment. So register my organization are the steps to getting a Z-code. Let me just make sure I didn't miss a slide here. Okay, yeah. All right, so how do I actually go through getting a Z-code? There are 3 steps. Number 1, you register your organization on the DEX exchange. And that takes you 5 to 7 business days, and it's just very few questions. It's your CLIA number and your tax ID and the name of your lab and your address, and then whoever's going to be logging into that, system. Then you're going to need to add a test. So adding a test, there's a workbook that is somewhere on their FAQ site. I ended up putting it on my Google Docs because they kept moving it around. But this is a good prep worksheet to work through so that when you go into the tool online, you can start making selections, and you don't have to have 5 people trying to log into that thing at the same time. But this does describe in about 36 columns all of the elements of a Z-code in terms of how they classify your Z-code, but it doesn't take into effect any of the real information that they're looking for, which is all in your technical assessment. And I will show you those 2 just to kind of really drive home a point I'm making here. So you identify your test ID, probably whatever the ID is in your LIMS is a good idea. Your test title will be the same title that it's called on your requisition, because when you submit for your technical assessment, you also provide them your requisition, and they're going to be matching it up to what you said your Z-code was, and make sure that that's what it is on your requisition, and that your requisition allows for individual ordering if you are saying that you're going to stack Z-codes in the manner that you would in single gene tests being done for PGX, which you can also do as panels as well. Are you the performing lab? Yeah, and obviously the whole point is if you're not, you don't need to do a Z-code. So that's kind of a silly question, but that's why they tell you no. Then this test is, then contact customer service, because they're going to tell you, yeah, you don't need a Z-code. And then is it intended for a Medicare beneficiary? So this question is going to become more and more relevant because you are now going to start seeing commercial payers like United start asking you to use Z-codes. Test description. Usually you're talking about the IFU, and maybe you're going to be talking about the name of the instrument, and you're just explaining to them what the test does. Then you have your molecular component or analyte. So you tell them what chromosomes you're testing, what alleles and variations or mutations you're testing. And then, for certain kinds of testing, you're going to talk to them about the mutation type. If it's not relevant, you can actually put in not relevant or not applicable. Then they ask you a whole bunch of stuff if you're FDA approved. Yeah, if your test you're doing is an FDA approved test, you are supposed to get a Z-code and technical assessment. It so says in the Palmetto website, but in your syndromic LCDs for Noridian, WPS, CGS, and Palmetto, they actually tell you you don't need a Z-code in a technical assessment if you're using an FDA-approved test, and it's only one test, and you use it in the ways described in the IFU, and there are no deviations, then you can bill and be paid for that test without a Z-code and a technical assessment being successfully completed. And there are several tests that are FDA approved for respiratory pathogen panels and meningoencephalitis and the women's health panel that they talk about. There are none that Medicare is aware of, according to their documents, that if you look at the response to comments, for a UTI. They're very specific about that, but they wrote that about a year ago. So maybe somebody since then has done that, although I have not heard of such a thing. So everything in purple is all kind of about that section. And then you get into these category sections where you're starting to do drop downs, right? So you put in your test type and your diseases and disorders. And again, they're just selections for you, but you pick the ones that are appropriate. And then you know the methodology, like it's PCR real time or PCR. There are like 5 different kinds of PCR in there, and I can't remember any of them right now off the top of my head. And then you put in your medical specialties, like who are the kind of doctors that order it. So what you're doing right here is you're setting yourself up for a really important element of what you're doing in the context of PGX or infectious disease. You're telling them who you think is going to be ordering it. You're telling them what disease states it's going to be covering. And that has a big impact on whether they're going to pay you for a small set of pathogens or a big set of pathogens. And then this all is backed up by what your technical assessment looks like. Now, really, the only impact that you could really expect out of your billing company would be what CPT codes are there that you would bill for it. But it's almost irrelevant because most of the time they're going to take whatever you've done and collapse it into that one code. If we're talking about infectious disease, which will be 87999. And in the context of something like PGX, it'll be the individual codes if you're doing singly ordered, individually ordered tests that you have multiple tests ordered at the same time. But as soon as you get into talking about doing a panel, they're going to tell you what code to use, and they're going to tell you what price they're going to pay you for it. And then there's a couple of other questions like, does it use an algorithm? And there's a definition of what that is. And do we have comparable assays and specimen type and handling instructions? And there, if I would provide a little bit of advice when you're doing a Z-code, nobody doesn't get a Z-code. Everybody gets a Z-code unless you've really screwed something up, like you obviously said that it was F510K and it's not, right? Or you put in something that doesn't gel with something else. So my attitude on it is put in only what's required to put in. And if it says optional, you're going to be taking care of that in your technical assessment, or they'll ask you a question about it later. I have seen people get dinged on their Z codes for, just silly things that are out of alignment with what they're supposed to be, but not a problem at all to fix. They'll tell you exactly what the problem is. You fix it, you'll get your Z code, and it'll say active at some point. And usually it's a 2-week turnaround. And so far, I haven't seen anybody not get a Z code. What I have seen people not get is their successfully completed technical assessment, which we're going to take a look at one right now, just to kind of show you how in depth that is. So then once you've got your Z code, right, which, within 2 weeks, they're going to have sent it back to you, and sometimes even quicker. Then they're expecting you to turn in your technical assessment within 15 days. So originally I would advise people, look, don't bother filling out your Z code until you're about 2 weeks away from being done with your technical assessment, because you're going to get your Z code and it'll be quick. And then they're going to expect you to submit your TA within 15 days. I've had people submit later. You just have to talk to them a little bit. Sometimes they might go in and inactivate your Z code. You have to say reactivate it, and then you can submit your TA. It's not really that big of a deal, but that's kind of what their expectation is. And that's what they'll tell you in the FAQ. All right, let's take a quick look at a TA. Oh, there's a very important element about these technical assessments, and that is they keep changing them. So the form that you download before you do your TA even if you've downloaded one last week, go in here and download the latest one, because they keep updating them all the time and they keep adding things. And so you don't want to get to the end of doing your TA and then they're like, yeah, we've added another tab now. And so you got to go back and redo your work, right? So analytical validity, clinical validity, syndromic infectious disease panels, right? And as you can see, there's NGS solid tumors, myeloid tumors, inherited cancer, the prenatal carrier screening, which I guess they must have put that in there for like Blue Cross Blue Shield of North Carolina, because they're not doing that for Medicare, right? But anyways, this is where you find it. So you've got a PGX one and you've got a syndromic infectious disease panel one. And they download as a little spreadsheet, and then they open up as a spreadsheet and enable editing. Yeah, and they must have made a change to that again, because usually it doesn't look like they've got that giant thing there. So you'll have one page, which again is just, see, you can't even start doing this until, well, you can't turn this in until you have a DEX code identifier, right? So that does solidify the order that this happens in, but you could be working on it before you have a Z code. That's not a problem, right? And they do want you turning it in within 15 days of them saying you've got a Z code. All right, so then you have analytical validity and clinical validity. And this is all about, and they also look at it at sample level data. This is all about how you did your samples, and are you going back and looking at it as a reference comparative point to the gold standard like cultures or not, particularly for infectious disease. They've got this kind of an issue where they'll bring it up that, oh, you validated against somebody else who validated against somebody else who validated against a PCR machine, and nobody's validating against the gold standard. They're probably going to have an issue with you on it, but it depends on everything that you're doing, right? But if you haven't collected the data in the right format, when you did your LDT and you don't have, separate specimens for each one of the pathogens that show positive versus negative in the context of a panel that you're talking about for this data, they can ding you on that kind of stuff, right? But usually right now, they don't even bother looking at that, because what they do right now is they go back to the literature section and they look at the clinical utility section and they look to see what you've written down. And oh yeah, by the way, they've posted online a 5-page document in PDF form of all of the clinical utility, all of the clinical peer-reviewed literature for the clinical trials that everybody has so far put forth to Medicare have all been rejected. So rather than them wasting their time to try to teach labs how they think an LDT should be done, they just go to the back now and look to see what you've written down there. And if there isn't something new for them to look at, they just send it back and go, you don't have clinical utility, and then you're done, right? This is not the same kind of issue that you would have with a PGX submission, though. With PGX, as you'll see here momentarily, they don't even have a clinical utility section, and that has a lot to do with the entire LCD that they have, and they basically pushed off medical necessity to the CPIC and the FDA. But you have your AV and CV sections, right? And they give you even an example of what they expect that kind of stuff to look like and how they want that test done, and they've got their sample level data. That's new to me from, I think, last month when I looked at it. I don't remember there being a sample level data section. So yeah, if you had used what you had pulled down last month, you'd be missing a whole tab right there, right? Oh, and then another really good thing for you to do is you update the change log. You incorporate the emails that they send back to you in it, because when you contact MolDX and you have somebody reviewing it, it might be a different person, and I'm getting wildly different results out of different evaluators under MolDX, as if they might have more qualified people and sometimes maybe less qualified people working on different aspects of it. And presumably, would they have geared up and staffed enough to be ready for the massive amounts of, all the labs that are going to come in? Probably not. So maybe we will expect delays again, as we did at the beginning of the mad dash to try to get Z codes for UTIs about a year ago. Well, there's going to be a mad dash for this now, obviously, for everybody wanting to try to still get paid from United Healthcare. So maybe timeframes will slow down a little bit. But now, after having said all of this, I think it should make it very clear to anybody that a Z code in its own right is useless and means nothing to the payer until it's a covered Z code, which only happens after you do your technical assessment. So the question of, does United require only a Z code, or do you need your technical assessment too? Yeah, they're going to be wanting your technical assessment too. They're going to be integrating with this system, and they're going to look for it to say covered, right? And just to kind of give you an idea about what some of this stuff looks like, I've got a last file here. So this is what it looks like once they give you an active Z code, and an active Z code is not necessarily a covered Z code. Why are they making it so confusing? Well, it's because they're trying to respect the process. And so you can get a Z code, and it might take you 6 months to get through your technical assessment. In that intervening 6 months, you've had an active Z code. Well, now you can go back and bill it, presuming you're within the timely filing limit, which for us up until very recently has been 1 year, because we're talking about Medicare mostly. Now with United, are they gonna, you're in network with United, you got 30 days. You're out of network, I think it's 90 days. So are we gonna be able to say, well, it took me 6 months, but my active Z code was active 6 months ago, but I can only go back 3 months, or can we appeal it? Yeah, you're probably going to be able to appeal it. And then for those of you who believe that, yeah, just having a Z code is going to be good enough for United, and you bill it and you get paid, that might actually happen for you. That actually happened with a lot of the Medicares. But you would be in a position of weakness in that they would have their rights to come back and ask for a recoupment if you never get your technical assessment approved. And so that kind of consideration, I'm not sure what the most appropriate way to handle that would be. That, let's say they try to take money back from you, but then later you do get it covered, and then you got to go back and bill it again, or are we going to be able to appeal and wait and then go back to the very first active date of our Z code? We're going to have to work through this and see what we can do with the payer. But what you're looking at right here, it would give you the lab test ID that you put in. It would be your name here for the lab. You would see your Z code here. And then what you'll see are the CPT codes that you put in for your Z code. This is what it looks like before your technical assessment is approved. You're going to see all of the CPT codes that you asked for. But then, like I was kind of mentioning earlier, they only want you billing one CPT code. And so they're going to say, okay, well, we're going to give you an 87999. And at different times, they would handle this differently. A lot of times these would just be left blank here, and I would still just see it as non-covered. Well, now I'm also saying after a certain couple of steps they get in the process, and I think they know enough about what you're doing from your technical assessment, then they might say, okay, I'm telling you it's an 87999 right now. Or in the context of PGX, they might actually give you the actual PGX code. This was obviously I think that looks like a UTI. So, that would be most expected for a UTI. If I had been doing, say, a respiratory pathogen panel, I might very likely have expected to get an 87631 or 32 or 33 or 36 or 35 or 37 if that's the test I was doing. Actually, not a 35. Any test that you're doing that's a single pathogen test does not require a Z code and a technical assessment for Medicare. United hasn't said anything about that. My presumption is that, yeah, you'd still get paid if you did COVID by itself, which will, by Medicare rights, is now going to be $51 in some regions and $35 in other regions. And when the clinical laboratory fee schedule is updated, it's going to be $35 across the board. And you can expect a similar thing to happen to us for COVID as the next year or two progresses beyond. It'll just end up being $35. And technically, if you're not doing it on a separate methodology, it should be subsumed into the viral target code anyway. So $142.63 is what you're going to get. Let me go back on two additional elements here. Boom, let's go back this way. Okay. All right, so we have been talking a lot about the infectious syndromic panels. Will I get a Z-code covered? I think the thing to understand with the context of actually being able to get a Z-code, so far, the only Z-codes that I've heard anybody getting are from LabCorp requests getting some smaller STI like chlamydia, gonorrhea, trick type panels paid or Z-coded up with a successful technical assessment having been completed. Like I said, everybody I know that's even tried to get a Z-code for anything that exists in the policy has gotten a Z-code for it and is active, but you can't bill for it, nor will you get paid for it from Medicare because you don't have a covered Z-code anymore, although they were kind of messing that up and paying people because they just didn't have their system together. And that's actually a thing to do with Medicare because there's a Social Security Title Act that states that Medicare has to pay for things within a certain time frame. And so that's why they do what they do. They look at what they can look at on a claim form, and in as much detail as they can, they will try to, edit things out. And that's what you see an LCD doing, where it says, oh, you build this CPT code in combination with this diagnostic code, then it passes. But if you have a CPT code and it doesn't have one of those diagnostic codes, you'll see that kick out as a denial. And that's basically the only thing they know how to do to stop you, unless you're in a MolDX MAC and they can start now looking at the Z codes. They can do that to now say, oh, you don't have a Z code, so I'm not paying you. But it took them a while to get themselves together. So you can, if you're looking at trying to get a Z code and technical assessment passed, I would pick something that is in the syndromic panel LCD that does have diagnostic codes associated with it, because if you recall, the reason they're just going to look at your clinical utility on the UTI and throw it out the window, they're not going to do that in the context of these panels because they already have defined medical necessity. They already have defined diagnostic codes. So you're not having the same fight. Now the fight is really about your analytical validity and your clinical validity. The clinical utility is already understood and agreed. You should be able to find documentation that supports it. So to be clear, I'm going to just show you very quickly the syndromic panel billing and coding article. This happens to be for Palmetto, but Palmetto, Noridian, CGS, and WPS are all verbally the same, verbatim, in terms of the letters that they've got on this page. But there were slight variations on the date of implementation, about a month off on some of them. And what I'm basically suggesting is, yeah, if you were going to try to get a Z code for anything, something that's in this billing and coding article, like a targeted respiratory pathogen panel, this would be your target. Do one of these. And you will only need a symptomatic diagnostic code in addition to your Z code and that CPT code to get paid for, or use an FDA approved and cleared test, and then you can bill them with impunity with no Z code or technical assessment. United has been silent on that topic. I suspect that they're just going to say you need a Z code and they're not going to go with just FDA approved. And that actually is in alignment with what Palmetto said, which is in contradiction to what this LCD states. They don't state that you need a Z code when you use an FDA approved. In fact, they tell you you could just use an FDA approved one and get away with it. But if you look at Palmetto, they'll actually tell you, yeah, you need to get a Z code even when you're using an FDA approved test. And hence, I do believe United will follow that level of detail because that's what they do in everything they do. They're very detailed. So group 2 is a targeted gastro panel. Yep, another good one to do for you here. 3 to 5 targets. You're going to get paid $128 for this test, and you just need one symptomatic diagnostic code. And actually, in the context of comparing this to a non-MolDX MAC, if you were in Novitas or First Coast, the only code that would cover it would be R19.7, acute diarrhea. You will actually have access to many more diagnostic codes, including fever. So getting a Z code for this and being in a MolDX MAC actually would be an advantage if that's the level of panel that you want to build. Now, when you talk about group 7, which is also a gastro panel, but it's the 6 or more pathogen panel. Well, now you're going to have a problem getting paid for that without also having a specialist order it, which within the context of GI would not be a bad expectation. But you will also need to have 2 diagnostic codes, not just one, a secondary diagnostic code that is talking about the immunocompromised patient. The meningioencephalitis panel, that would be a good one. Bloodstream infections, you got a good chance to do it here. And then the UGAG panel is really talking about women's health, or you end up billing this code or one of these codes here for an STI. That would be a good chance for you to target getting the Z code, but not UTI, not nail, not wound, not dermatology, not ophthalmology, not anything that doesn't live in here. Now, all those things I just got done saying that are billed with all of these individual pathogen codes, they don't really live in here, and they're telling you they don't want to pay for these and that they're not going to pay for these. And you won't be billing those codes. If you actually do get a technical assessment, it'll be an 87999 anyways. So I wouldn't even bother trying to get those until we know that there are clinical trials for that. Lastly, I did want to touch base with you on Z codes for PGX and point out something very quickly, and then I could leave some time for questions. Do we have questions, Linda?
Not at the moment, sir.
Okay. All right. So PGX, yeah, it's a lot different getting covered. I usually see people, they get their Z code in about 2 weeks. They get their technical assessment turned around in about 2 weeks. So you could expect to get done within a month or 2 months, depending on how long it takes you to get done with you performing your technical assessment. They seem to be responding back in about 2 weeks. But that could change given the fact that there's probably going to be a lot of people trying to get them now again. I did want to take a moment to describe what a panel is versus single gene test. So single gene test is anything where you're looking at a gene, but that is confusing as all get out for people a lot of times, because we as a lab, we're going to use the term panel to indicate everything I'm running that I've set up on my methodology for my machine that I do in one run. That's our panel. When we use the term panel and for billing purposes or for coding purposes, we're actually talking about a subset of that thing that you ran that you call your panel. There's a subset of that for a panel. And in this context, what they're talking about as a single gene test is when 2 or more different single genes are ordered individually, but at the same time, that's not a panel. That's me saying as a doctor, yeah, I want to check out tricyclics, that's 2D6 and also 2C19, and I'm ordering this med. That would be one single test that may or may not cost both genes, because with 2D6 and 2C19 with tricyclics and SSRIs, I can actually cover 2 genes with one med. But like CTFR for cystic fibrosis, and I ordered that and I said, yeah, my patient, I'm prescribing Ivacor or Ivacaftor, whatever they call the drug, and I want to evaluate this for selection, avoidance, or dosage. And then I check marked that that's what, then I ordered that gene and that test individually. And if I went and then ordered something for a proton pump inhibitor and something else, I would have 3 different single gene tests that I ordered individually that I would need to be ordering on that requisition as individual check marks. And I would have individual diagnostic codes for each of them. And I would be getting paid for all 3 of those under those individual criteria. Now, they also have the concept of a multi-gene panel, which is where you're doing at least 2 genes. Now, here's what's most important about that. If you want to be covered for that, where is it? A multi-gene panel is considered reasonable and necessary if more than one single gene on that panel would be considered reasonable and necessary for the safe use of the medication in question. Okay, so there are crossovers for 2D6 and 2C19, which would translate to an 81418, which is our new bundled code, which we have no clinical laboratory fee schedule for, but we do have people already getting approved Z codes for that code, and it appears to be worth about $915, which would be better than billing a 2D6 and a 2C19 as individually ordered, separately ordered genes, that'll add up to about $750. So you would make more money, and it would be easier because I'm only going to need one diagnostic code if I'm talking about one med that crosses both of those genes, and I would only need the doctor to make one check mark box. Now, there's a lot of detail to go into that, and if people are interested in that, you should email us back so that we know we've got enough people to be interested in having a very specific a webinar regarding PGX and the difference between single gene ordered medical necessity and panel gene ordered medical necessity and what panels we've got. But in a big criteria overview, as long as you've got a panel with a Z code and you've got 2 or more genes that are genes that are at CPIC level A and B and FDA, and you've got medical necessity for ordering those 2 genes, then you can get a panel paid for. But there's a lot of work that goes into doing that. And when you're trying to get your Z code for that panel, well, they're not going to give you a Z code for your entire kitchen sink panel if you say it's for everybody and anybody, and you need to kind of put your boundaries around who your intended population is. And you'll note that
Hey, William.
Yep.
We have 5 questions. We have 5 questions in the chat for you.
Okay, let's do that.
Can you pull them up?
Oh yeah, there we go. Any information about Novitas and MolDX? Okay, so I bet what that question is Novitas going to be MolDX? I don't think Novitas will ever adopt MolDX because Blue Cross Blue Shield of North Carolina and Blue Cross Blue Shield of Florida are not buddies. And it's also kind of like admitting to somebody that you don't know how to do your job because you want MolDX to come in and do it for you, which may be okay to say and to certain people, but I don't think Novitas is going to say that. But the other problem with Novitas is they're 30% over budget. So they may lose their contract. I would be more worried about Novitas losing its contract and not being a MAC anymore than I would be worried that they're going to adopt the Z-code program, because we would hear about it probably 2 years before it actually worked. We'd probably hear about it a year in advance, and it would take them a year to implement it. And then it would probably take them another year to actually start processing claims correctly when they're trying to do it. And so there will be a long lead time. If Novitas is going to adopt MolDX, we would hear about it a long time in advance. But what's more likely to happen is these guys are going to get kicked out by Medicare because they can't control the spend. And that was mostly related to 81408, which continues to be identified by the OIG as a problem. So if you're doing NGS testing and you're billing 81408, get ready for clawbacks. All right, Nathan Allen, if we have a DEX Z-code, do we still need covered DX code? If we have a covered, okay, that's a great question. So in the context of infectious disease, yeah, your LCD, your syndromic panel LCD will explicitly tell you that you do have these required diagnostic codes. So having a MolDX Z-code does not relieve you of the requirement to have a specific qualifying diagnostic code as stipulated by the syndromic panel LCD. Now, in the context of PGX, this one that we're looking at right here, you don't actually have any required diagnostic codes. They actually put, oh wait, this is the LCD. That's why I couldn't find what I was looking for. Let me go to the billing code. Oh wait, there's the billing code. You'll actually see, oh, this is the, sorry. I thought I was looking at this one. There we go. So you'll actually see that they kind of give you a list of they give you a list of diagnostic codes here in the context of PGX, right? But these are not required at all, right? Not in any way similar to the way that Novitas has required ones like, oh, you're going to bill an 81225. Well, you better have a diagnostic code from code group 3 or 4, or they don't pay you, right? So there's that. When will Novitas adopt MolDX? I don't think they will. How much time from start till final registration that we can start billing that code it takes to register panel index MolDX Z-code? Okay, so 2 weeks to get your Z-code, assuming that as soon as you're done with your Z-code, you turn in your technical assessment because you've already been working on it. 2 weeks after that, you could literally expect it, but maybe buffer an extra 2 weeks in case that things slow down. So within 6 weeks, if you're ready to go and you've done your thing, that's about how fast it takes them to turn it around. They don't take too long to do it, but doing a technical assessment could take somebody weeks to do. It's rather involved. I believe you mentioned briefly that FDA-approved tests do not require Z-codes for the LCD, but Palmetto does require them anyways, even for PDA-approved tests. Is that correct? Can you elaborate? Okay, so yeah, what I'm saying is, if you read through the DEX FAQs, there's a topic in here that says, if my test is FDA approved, do I need to do a technical, do I need a Z-code? And they'll tell you, yeah, you need to do a Z-code and a technical assessment. But that's a part of the Z-code process. Is it's relatively, oh yeah, you're FDA approved, and that kind of will fast track you through it. So it will definitely help you if you're FDA approved. But the actual syndromic panel LCD states the following, and I'll show it to you in writing very quickly here. And I want to point something out. This is what I think confused a lot of people about this, is so everything that's under here is the general criteria for coverage for a molecular syndromic infectious disease pathogen panel. And anything greater than one pathogen that is not on it. Did you want to say something?
Oh, no, I'm sorry.
This policy is for anything that's analyzing DNA. Typically, they mentioned in the past it was nucleic acid amplification or any kind of PCR like those other different kinds they have, right? But not next generation, not mass spec, not FISH, right? And if you're doing only one pathogen, then this doesn't apply to you. But as soon as you're doing more than one pathogen, not more than 5 pathogens, more than one pathogen, the general criteria apply. Then after the general criteria, they do have limited expanded coverage for things that panels that have greater than 5 pathogens, like your meningio, RPP, or TIP. Now, in the context of everything, right, for the general, anything more than one pathogen, there's the words here that say services that do not have FDA approved and cleared uses, as well as an FDA approved test performed in ways not consistent with their intended labeling instructions, will require registration with the MolDX and a technical assessment to demonstrate compliance of service with this policy. So some people used to see this, and they would think that this bullet here meant that that only applied when it was greater than 5 pathogens, and it doesn't. All they're talking about here when they say this is they're saying, hey, there's more for you to understand down here in this section about limited coverage for expanded 5 pathogen panel, and this is the additional information on that. So in answer to your question is, this LCD is telling you you don't need to be a Z-code and technical assessment as long as you're using an FDA test. And I think that's important to understand. Palmetto is a separate entity from Medicare. They are not the same thing. Even though Palmetto owns the MolDX program, it's being used for other MACs, right? So it's a separate entity, and what they're talking about and what they do is separate. So if you ask Palmetto, meaning the MolDX program of Palmetto, not the Palmetto, the Medicare administrative contractor, then the Dex Exchange is going to tell you that, yeah, you're supposed to get a Z-code and a technical assessment. But right here, I'm not reading, it's not saying I don't have to have one. It's telling me I only need to get a Z-code if I'm not using an FDA-approved test. So I'm taking that to mean I can get paid for FDA-approved tests because I don't have to, it tells me that I don't need to have a Z-code and a technical assessment in the actual document. But for anything else that you do, if you used an FDA-approved test for, say, cancer, BRCA, or something like that, then yeah, you would need to go get a Z-code and a technical assessment approved for that, unless it says you don't need to do that in the policy, and the policy that Palmetto has, it doesn't address that. So I would get one. So that's a little bit funky about all this. If we are doing lab billing in Novitas related states, we don't need Z-codes. No, that's not true. You need Z-codes if it's a Medicare Advantage plan. And I went over what exact CPT codes that is. And if you are in, so it's Medicare Advantage plans, all of them, not just United. And now in August, you will be required, whether you're in network or out of network, whether you are in a MolDX state or not, you are going to be required to do a Z-code for United. And it needs to be a technical assessment successfully completed as well, which you will be able to get for your PGX, but you will not be able to get for your infectious disease. But in the context of United Commercial, they're only on wave 1, and it does not yet include the syndromic panel CPT codes yet. But you can guess within months after August, within the year, you will end up seeing that all of the CPT codes that Medicare is requiring Z codes for, so will United. That's the other thing. All right, looks like that's the end of all questions. Thank you so much for having joined us today and had this discussion. Please do let us know if there are other, oh wait, there's a raised hand.
I think there was one more question at the end.
Oh, okay. Let's do that. UHC needs Z codes for the 8,000 series codes after August. It's for all states and only for UHC commercial plans. Okay. Yeah, it's going to be in the 81,000 series set. They have attachments that tell you what codes they are. I had those up on the screen earlier. As far as UHC Medicare Advantage or any Medicare Advantage, they're on wave 9, and they include all of the codes except for the individual pathogen codes for infectious disease. You do have some of the bundled or group or NOS codes for the infectious disease that have Z code requirements on them, but like 87481 Candida isn't in there, right? So I don't know why they haven't done that. Probably at some point in the future, they'll release that they're doing those as well. Now, as far as United commercial plans, they are basically up to PGX and some of the CGX codes. There's about 250 of them. There's, I think, there's at least 4 or 5 times that many codes in that section that they still have yet to get to, right? But certainly not infectious disease yet. But if you're doing PGX or any kind of CGX, I would definitely look at it. Well, anything you're doing with DNA and RNA, just look at the list and see if you've got them in there. But that should do it. All right. Well,
Any other questions for William? Thank you, William, and thank you for all of our guests. Oh, we have one more.
Oh, more? Okay, good. Yay. Yes, it is for all states. Well, and so here's the problem. You're going to have leadership in your lab want to pull this apart and look at it. If you compare what they did when they talked about Medicare Advantage to UHC, they did and didn't specify, and then later came back and specified additional information. Is it for all states or not? Is it for this or is it for not that? But the way that you see it being written now, they're telling you it's for commercial plans. They're not telling you, oh, it's for MolDX Max and also non-MolDX Max. They're just telling you it's for commercial plans. So you can read what's written there and try to read it the wrong way because you're going to think it gets you out of a problem or something. And you might even bill it and get paid for it. But after a phone call and reading their document, it applies to all states, whether it's a MolDX Mac or not. It applies whether you're in network or not, that was the only valid question I really thought there was, because what United is doing is replacing Beacon. And while you can say that the commercials, we have to be worried about the commercials, but it's going to be more about the Blues that we need to be worried about, because they use benefit policy managers like Avalon, AIM, Carelon, and Avalon is already telegraphing that they've got a webinar that will appear in our newsletter, so you guys can have access to it. You should sign up for our newsletters. But they're going to have a webinar next month or maybe in August where they're talking about what plans they're going to be recommending utilize the Z-code. Now, Avalon is a benefit policy manager predominantly for Blues, but also for some Medicaids and some Molinas and those kind of things. So we will see, I think, the Blues adopt the Z-codes. I'm not super worried about a Cigna or an Aetna doing it. I see what United did. United was running Beacon, but they've sold Beacon off to Lighthouse, I think. And they're using the MolDX Z-code program to replace their Beacon program. And so originally Beacon was only for in-network. You didn't have to worry about it with out-of-network, which I think is why United decided to adopt it, because they can apply it across all plans. And that's what they told me on a phone call. So you can continue to bill and see what happens, but also do know that just because they pay you doesn't necessarily mean that that's right, because I do believe we're going to be looking at a couple of hiccups. I mean, United, I'm sure, is going to have their ducks in a row. It's the MolDX program and how they integrate with United, will that be working? Like maybe they feed over that the Z-code's active, and so then United is going to interpret that as covered, and then they're going to pay you. And then they're going to realize that they needed to get something that said active and covered sent to them so that they should be making the payment. And so there's going to be probably a little time where that's not all worked out and people are going to get paid for stuff that they shouldn't. And then will they come back and take the money back from you or not? Yeah, United's pretty good about that. Medicare, maybe they never do. I mean, and there's a lot of people that got paid for about a year on their UTIs that shouldn't have gotten paid. And I still haven't heard of anybody getting clawbacks. Medicare's a little busy with what went on with COVID, and I'm sure a lot of the payers are still kind of focusing on that. So do expect some turbulence in terms of stability and how this is all going to play out for us, right? It's going to be changed a lot over time.